Hi. Sorry I had so much trouble with my lecture. Hopefully we'll do better with this. Just type messages and we can chat back and forth, but let's have the first slide. Stephanie, I don't see anything. Okay, so this is an ARS question. Which statement is true about hepatitis C and HIV co-infection? Treatment of co-infection differs from HCV monoinfection treatment. The second is that HCV antibody protects against reinfection with hepatitis C. The third, spontaneous clearance is common after acute infection in people living with HIV. And the third is, last is HCC occurs after cure of HCV. We're over halfway. Pop in a few more. All right, I think we can end the poll. So what we see is that 82% got it correct. HCC occurs after cure of hepatitis C. And treatment for co-infected is the same as for mono-infected, except for the drug-drug interaction issues. So I think that you got the other questions right. Hep C antibody is not protective, and spontaneous clearance is rare in HIV individuals. We don't have any questions as yet, so let's go on to the next slide, Stephanie. Move my poll somewhere. This is a 63-year-old male with hypertension, hyperlipidemia, and HIV who was referred for abnormal liver tests. The lab showed AST of 63, ALT of 52, normal creatinine. Platelets were low at 78, albumin was lower limit of normal, INR was normal, bilirubin was normal. And his meds are omeprazole, rosuvastatin, dolutegravir, TAF, and 3-TC. I wanted to make a point about AST and ALT. Normally in hepatitis C and in fatty liver, the ALT is higher than the AST. So that's what you see when a patient progresses to cirrhosis. The platelets are low and the albumins at the lower limit are normal, all suggesting the patient might have cirrhosis. So the next slide. We think about liver function. We've done albumin, bilirubin, INR, and he does have a lowish albumin. He does have inflammation with AST and ALT. And so the tests that you would do to assess hepatitis B and C, and because he has hypertension and hyperlipidemia, would do his fasting glucose, triglyceride, cholesterol, hemoglobin A1C. And then fibrosis assessment, the bottom right, you can do APRI and FIB4 on on the internet, just with a calculator. So the next slide shows his fibrosis assessment. His APRI is 2.02 and greater than 1.5 is cirrhosis. And his FIB4, which is AST, ALT, platelets, and age, was 7.02, so that's cirrhosis. So greater than 3.725 is cirrhosis. So would you do a FibroScan and would you do liver biopsy? So we don't need a liver biopsy because his APRI and FIB4 clearly show cirrhosis. I'll ask the question, would you do a FibroScan if it's available? 1 is yes, 2 is no. Could you do that for me, Lee? Maybe not. Nope, that's not it. I just wanted to do a yes, no question. Take that one down. All right, so don't worry if you can't do it. Here, yes, no, here we go. Select 1. So does anyone want to comment on why, for those who wanted to do a FibroScan, why they wanted to do it? Maybe Mitchell or MediMission?
I don't really know. I just said yes because we have a FibroScan and we do it ourselves in the clinic.
Well, we have a FibroScan and we do it ourselves in the clinic too. So actually, it's in this patient, remember, we think he has cirrhosis, but there's, and FibroScan goes in Hep C, cirrhosis is 12.5 or more kilopascals, but it goes up to 75. So you can have a touch of cirrhosis at 13, and you can have a hell of a lot of cirrhosis at 50 or 60. And actually, FibroScan is actually very useful in is very useful in assessing portal hypertension. So we know if the FibroScan is below 20 and the platelets are greater than 150, you don't have to worry about portal hypertension. But in this patient, the platelets were 78. So it wouldn't actually matter what the FibroScan showed. You still think he has portal hypertension. Of course, there are other causes of low platelets in HIV. But I'm like you, I would have done a FibroScan to use it to monitor in the future. Because since he has fatty liver disease in addition, even when he's cured, you're going to worry about that. I would want to assess for HCC. Yes, completely true, with a right upper quadrant ultrasound. But I don't think you'd, for C1-2, I don't think you would get a negative elastography in this patient. What are your concerns about using buprenorphine or naltrexone in patients with liver disease? It is okay in using it in patients who need it for their treatment of drug addiction, and nice studies have been shown with buprenorphine and Hep C treatment. Of course, you'd be monitoring the liver tests anyway. So I think the benefits of addiction treatment outweighs any issues, but you'd need to monitor the patient. So let's stop sharing that. So get rid of that result. Oh, can I go back to my slides, please? Oh, something happened. Stephanie, can you put my slides up? Or is it Karen? So we don't do a liver biopsy. We did an ultrasound that showed a nodular liver with splenomegaly. It's the splenomegaly that helps confirm everything else above there. Cirrhosis by APRI, cirrhosis by FIB4, FibroScan was 29, so that goes with it. You don't need a liver biopsy, and his viral load is 5 million. Next slide. So he has cirrhosis based on FIB4 nodular liver, high HBV DNA, high HCV RNA, doesn't have ascites, doesn't have asterixis. He has low platelets. Next slide. So the treatment. So what I'm going to say about treatment is just look it up on the web. Having it in your head doesn't help anywhere. I mean, hcvguidelines.org have all the treatments. So here's a treatment-naive genotype 1 patient with HIV and compensated cirrhosis. And you have choices. You have 2 pan-genotypic and 2 specific for genotype 1. And it really depends on, in our case, is what the insurance companies will pay for. You know, we can make all the choices we like, but we need to think, if the insurance companies say, no, you have to give Sofvel, then you have to give Sofvel. But these are all equally agreeable. And the second thing is, I think on the next slide, drug-drug oh, no, let's go to the next slide first. So drug-drug interactions is the only issue. So we're fortunate to have a pharmacist in our clinic. So we give them the list of drugs and they tell us what to worry about. If you aren't that lucky, the University of Liverpool website, and you can Google it with University of Liverpool drug interactions and look up HEP drug interactions checker, and it will give you a site that you put in rosuvastatin plus ledipasvir and sofosbuvir, and it'll say, do not use. So you can either stop the rosuvastatin for 12 weeks or choose a different statin. For omeprazole, if you put it in with ledipasvir and sofosbuvir, it'll say take them together on an empty stomach. If you put them in with sofosbuvir and velpatasvir, they'll say take DAA with food, then the PPI 4 hours later. I really think you can't keep it all in your head, but it's critical to put in all the drugs to be sure you know the best medication to use. Now, if you go back one, please, Stephanie, or is it Karen? I don't know. You may have heard of simplified treatment for hepatitis C, and on the website they have that, but it is not recommended for HIV. So if you go back one more, you need to hit the website, the part of the website that says HIV and hepatitis C. So these are the guidelines. So if you go forward 3 more, I think treatment of Hep C has become much, much easier. So I'd like to have a 3 poll. Number 1 is no follow-up. Number 2, follow-up for concomitant disease. Number 3, follow-up for cirrhosis. Karen, sorry, please do. If you could set up the poll. 1, 2, 3. Go back, please. Go back. Karen, could you go back? Yeah.
Sorry, Lee, can you set up the impromptu poll, please?
Okay, please vote. No follow-up, follow-up for concomitant disease, follow-up for cirrhosis. Okay, end the poll, and nobody wanted no follow-up. Excellent. And yes, you need to follow up for concomitant disease, and yes, you need to follow up for cirrhosis. Excellent. Thank you very much. Next slide, please, Karen. So we know he's cirrhotic. You could stop sharing that. So he needs 6 monthly alpha-fetoprotein and imaging. And I don't know if anybody has questions about that, but let me know if you do. The data for alpha-fetoprotein are that alpha-fetoprotein can be elevated in patients without cirrhosis. So in the a study of co-infected patients, when you treated their hep C, the alpha-fetoprotein came down. And the second bad news is alpha-fetoprotein can be normal in patients with cancer. So it's not a perfect test, but used in combination, if a patient has an elevated alpha-fetoprotein and has a tumor, you can monitor the alpha-fetoprotein to see response to treatment and recurrence of disease. And in certain areas where, how do I get, can I just get rid of that poll? Yeah. So in certain areas where you don't have imaging, alpha-fetoprotein's been used, like in the Alaskan natives, and has done very well in terms of monitoring for HCC. The hematologist or the hepatologist. So there are 3 guidelines: the Asian Pacific, the European, and the American. And one guy in America hates alpha-fetoprotein, so he was in charge of the American guidelines and deleted it, whereas the rest of the world had it in. So he retired and somebody else became the guidelines chief, and alpha-fetoprotein is back. For all its warts, it is valuable. So we recommend imaging and alpha-fetoprotein every 6 months. His FibroScan was 29 and the cap was 380. And I have a slide to show you about a controlled attenuation parameter, which looks for amount of steatosis. So he has cirrhosis and portal hypertension. He needs imaging, alpha-fetoprotein every 6 months, and he needs treatment for his metabolic syndrome. His hemoglobin A1C was 6.5, his elevated fasting glucose. We need control of weight, diet, diabetes, cholesterol, limit alcohol, avoid THC daily. Even though he's cured. Sorry, Maggie.
Dr. Peters, I'm just curious, do you have a ceiling with how aggressive you are with statin treatment in these patients? If you want to reach lipid lowering goals from a metabolic standpoint, can you push it to your most intense statin dose, or are you more cautious?
So patients with fatty liver or any liver disease are no more at risk for statin hepatotoxicity than you or I, but you need to monitor for it. So I would start low, go slow. I think that's good advice, but there's no reason not to increase if you need it. This patient clearly needs ongoing monitoring, A, because he's cirrhotic, and B, because he has fatty liver. One question is, what would happen if he had F2? So if it were this patient who had F2 and we cured his liver disease, right? So his FibroScan was 7.8, then you would say, well, he needs ongoing monitoring for progression of fibrosis from fatty liver. If he had F2 and no other liver disease, no alcohol, no metabolic syndrome, no diabetes, then I would not be monitoring him. I hope I answered my question. How many drinks per day per week? Well, what the doctors always say is more than me. For women, it's less than 7 drinks a day. For men, less than 14. If patients, that's moderate alcohol. And clearly, for women, 3 to 4 a week, and for men, 7 a week is ideal, and not all at one sitting. Oh dear, where am I? Any hep C in patients who have PCT or cryoglobulinemia. So it's interesting because so much of PCT is hep C. So in the same time, porphyria cutanea tarda, in the same time as you need to monitor the patients, protect their skin from sunlight, treat their hepatitis C, and even phlebotomy if they have a high iron load. Otherwise, you treat their hepatitis C the same as you treat patients without PCT. And for cryoglobulinemia, the treatment is identical. If patients have skin manifestations of cryoglobulinemia, they almost always go away with cure of hepatitis C. If they have glomerulonephritis, they often go away, but not always. So if you look at big studies in patients with vasculitis, therapy can reverse that, but it is not 100%. Some patients who are on dialysis come off dialysis, so patients should definitely be treated for should first of all be checked for hep C if they have cryoglobulinemia, and should definitely be treated. And you are completely correct. Many patients with PCT completely resolve with SVR, but not 100%. So I think I answered all those questions so far. Next question, next slide, please. So which statement is true in fatty liver and HIV? Fatty liver is uncommon in HIV. Liver disease is uncommon in HIV patients with fatty liver. FibroScan can measure fat and fibrosis, and ART does not lead to weight gain. Okay, let's see. So FibroScan can measure fat and fibrosis. That's correct. Fatty liver is exceedingly common in the general population, about 35%, and it appears to be even more common in HIV. And liver fibrosis, in the small studies that have been assessed, show that it's more common than it is in the general population. Next slide, please. So this is how you do a FibroScan. I think everybody's familiar with this. It's a tiny little portable machine, and they even have hand machines now. You measure it between the ribs. That can be a problem in obese patients. You get an amplitude. You can see down here between the ribs, and you get a measurement of the amount of fibrosis. The next slide shows, goes from 2.5 to 75. And these cutoffs slightly vary depending on what disease you have. If you have acute hepatitis, it will be up here in the cirrhosis range because high ALT causes high FibroScan falsely. So you don't do it if the ALT is over 100. But cirrhosis, you can see the difference between just saying cirrhosis, yes, no. This shows you actually the amount of cirrhosis. The FibroScan machine is, I think, $120,000. Now, the hand FibroScan machine may actually be less, but I can't answer that. And you can also negotiate with them for a price. Next slide shows in a patient who's obese, you can see that the skin to liver, if it's greater than 2 centimeters, you won't get an accurate FibroScan. So if you have greater than 2 centimeters, you need to use the extra large probe. Next slide. So the false positives are acute inflammation. So if the ALT is over 100, liver rejection, cholestasis, hepatic congestion. I had a patient with hep C who came in for his FibroScan that showed cirrhosis, but his FibroScan a year before had shown F0 to 1. So it was like 5.4. So I said to him, this doesn't make sense. Was anything different about you that day? He was, you know, a slender guy, no problem. He said, well, I actually got an attack of paroxysmal atrial tachycardia just before I went in to have it done, and it went away, so I didn't worry about it. So if you get hepatic congestion, it falsely elevates. So patients who have heart failure, older patients who may have some ischemic heart disease and a little bit of increased flow after eating. If you have a big meal and go for your FibroScan, your score goes up. You have to be fasting for 2 hours. And alcohol can raise it. It may be too hard if the patient's too fat or too thin or has a lot of vessels. And a big problem, it is not a good test after the cure of HCV, because the ALT, which might have been 56 at the time of FibroScan, goes down to 11, and that's enough to decrease the FibroScan result without doing anything to assess how much scarring there is. Can I hold off on Tekavir till I get to the B slides? In co-infected, is it enough if you get an APRI and a FIB4? I think if they're both in agreement and that they're both elevated, like in this patient, I would have gone ahead and treated that patient as cirrhosis without trying to get a biopsy or FibroScan. So there was a question about only recommending ultrasound alpha-fetoprotein for F4. And actually, that's what the US guidelines say. The European guidelines say F3 and F4. So if you want the insurance to pay for it, you have to say, give them the European guidelines to agree. Next slide, please, Stephanie. So what does CAP measure? It's the controlled attenuation parameter. It measures the attenuation of the ultrasound signal. So the next slide shows, oh, back one. So it tells you how much fat there is. So if you're over 280, that's steatosis 3, and it goes up to 400. So his steatosis was 380, so he clearly had fatty liver. So I go back to, can you add entecavir to a 2-drug regimen to cover hepatitis B if core antibody positive? So the problem with entecavir, as you know, is the 184V mutation, that you can actually get resistance to hepatitis B. So it wouldn't be my ideal choice. Next slide. So which statement is true in people living with HIV and hepatitis B? E antigen positivity is lower. After acute Hep B, loss of surface antigen is more common in HIV positive than negative. Current hepatitis B therapies usually lead to loss of surface antigen, and ART initiation leads to loss of surface antigen in HIV subjects. This is how good or bad my lectures are. So if a patient can't take even TAF due to renal disease, we have very few patients who can't take TAF. If it's just tenofovir, yes, if it's TDF, I can understand it. But if you can get TAF, then that may resolve a problem of a patient who's surface antigen positive. So let's share the poll. ART initiation leads to loss of surface antigen in somewhere between 10 and 20% of patients. And that's been shown in Asia, in Europe and in Africa. Current HPV therapies don't lead to loss of surface. It's really in the single digits. So the current therapies we have are polymerase inhibitors, and they rarely lead to loss of surface antigen. That's why we need new drugs. After acute infection, loss of surface antigen is more common in HIV negative patients. In adults with acute Hep B, less than 5% go on to chronic, whereas adults with acute Hep B who are HIV positive, about 20% go on to chronic. And there's a much higher incidence of E antigen positivity in HIV patients, about 80%. So go to the next slide, please. So this is a 24-year-old MSM with HIV diagnosed in 1990. Surface antigen was positive in 1997 with a high viral load. That's 9 logs copies, which is about 8 IUs per mil, 8 log. He was put on ART with lamivudine and became anti-core positive alone. And then in 2004, he developed diffuse large B-cell lymphoma. And they were going to treat him with steroids and CHOP. So my question is, should he be on hepatitis B therapy? Yes, no. And Lee, can you do a poll for yes, no? Should he be on hepatitis B therapy as well as ART? Or should he be on ART more than lamivudine? Get to the magic 70% and then we'll stop if we can get there. Yep. Okay, we can stop. So yes, he should be on HPV therapy. So you can stop sharing. And someone very wisely said, C1-2, he is at risk for relapse of infection if rituximab is added to his regimen. And so the next slide, let's see what happened. So, rid of that. Can you see my pointer? Can anyone? No one can see my pointer. Okay, so I'll read it. So his treatment was lamivudine, efavirenz, lopinavir, ritonavir. Was back in the day. He was put on steroids, top column, and CHOP. The arrows are how many CHOP he had. Then if you go down, he was diagnosed with non-Hodgkin's, and in the orange at the very bottom is his ALT. He didn't have HPV DNA performed, but they were storing serum. So you monitor his ALT, and you can see June, July, August, September, fine. October, it gets a little bit up, and then it goes up whopping over 1100 at the end of the year, which time they evaluated him. So we go down. He was core antibody positive all the time. He became surface antigen positive in July, August, September, October. He became E antigen positive, and his HPV DNA, which they retrospectively did, you can see it was undetectable when he was diagnosed. It was undetectable at the first couple of CHOPs, and then it started to go up. And 3 months after it went up, he developed severe acute reactivation. So there's a number of issues here. Number one is that you can serorevert from core antibody positive to active viral replication with surface antigen, and HBV DNA goes up first before surface antigen and before ALT. And then he was put on Adefovir because that was the fancy treatment at the time. And you can see his ALT came down and his HBV DNA came down, but he'd missed 2 courses of CHOP. So his lymphoma recurred. So the problem of not putting him on aggressive HBV therapy before starting CHOP was delay in treatment of his non-Hodgkin's lymphoma and a severe flare in his hepatitis. And there have been over 20 cases of deaths in the literature with CHOP in anti-core alone patients. So next slide. So the issue was that there's a delay in chemotherapy and there was a dramatic decline with Hep B therapy, but if he'd been treated with Hep B therapy from the beginning, he would have got a full dose of treatment. Now, why couldn't he be immunized? Because he already had hepatitis B. He was what you would call immune, and the next slide shows you that it's not immune. Next slide, please. So this is the life cycle. And I just want to show you have the virus outside the hepatocyte. It enters into the hepatocyte, uncoats, goes to the nucleus where it's repaired into covalently closed DNA, which is the template for transcription of the virus. So you make virus that then goes back into the cell or out to infect new hepatocytes. And this individual is surface antigen positive, has active viral replication in the cytoplasm, secreting virus into the bloodstream to infect other cells. The next slide shows what happens when that person is so-called recovered. And I like to call that patient latent, but the term has not taken on. This immune system thinks the patient's recovered. They could be surface antigen negative, anti-core positive, anti-surface positive. There's nothing going on in the cytoplasm. It's silent. But in the nucleus, you still have CCC DNA. And this CCC DNA can be turned on by steroids, but steroids aren't super good at it. But anti-CD20 is fabulously good at it. It's about 10 to 10% risk of reactivating hepatitis B. And it's higher in patients who have HIV because they have further immune suppression. So profound immune suppression can turn replication on. And that's why when we look at why don't we vaccinate an anti-core alone? Well, if you vaccinate, then you just induce anti-surface that was below the level of detection. But you don't eradicate this risk of anti-CD20. And you can see it most prominently with anti-CD20, but it's also been reported with TNF and rarely with steroids and other immunosuppressants. So if patients with HIV and anti-core alone need chemotherapy, put them on a B drug. It's really critical. And I wouldn't choose lamivudine, but I wouldn't choose entecavir because this patient was, if you go back 2 slides, another one, sorry, go back another one. This patient was lamivudine resistant because in spite of lamivudine, he got a flare. So entecavir needs 5 resistance to the YMDD and compensatory mutations. Lamivudine only needs 2, but if you already have 2, it's easy to get more. So why do we even bother vaccinating Hep C antibody positive? Well, that is a great discussion. And I actually think it's not worthwhile because in this situation, it's not helpful. And If the patient never gets exposed, it's not an issue, but they do have cccDNA in the liver. And if you go forward to that last cartoon, next one, you can see that for all intents and purposes, this person is recovered. But if something happens to get the cccDNA transcribing again, then you have hepatitis B again. And there's data now that came out in the non-HIV literature of a study we did with anti-CD20, that it's a much higher risk of developing surface antigen if you're anti-core alone compared to anti-surface and anti-core. And why was this patient not immunosed prior to lymphoma? I don't know the answer to that. I think that we weren't super good 30 years ago in monitoring everybody and vaccinating everyone. But you can see from the Dutch data that there are some patients who don't respond to vaccine, and we're hoping that the Heplisav data will, with a strong adjuvant, will do more to turn on an immune response to the vaccine. So Stephanie, if you go back, I think one or two, another one. So there's a high rate of reactivation in immunosuppressed patients. So that is chemotherapy or HIV after immune reconstitution if you didn't put a hepatitis B patient on a B drug, after an organ transplant, rituximab, TNF, lymphoma. So even in those who've lost surface antigen and are positive for anti-core and anti-surface. So actually I'm not, even though I'm on those guidelines, I actually don't think it helps to turn, yes, I agree, you make surface antibody, but there's no data to say that affects the outcome. Except for the data I just told you in the mono-infected, where if you have surface and core antibodies, you might have less of a chance of seroreverting. So the next, I think that's the last of my slides. Oh, I just wanted to, I thought people might want to see what the new drugs coming down the pipeline are for hepatitis B, because I told you all we have at the moment are polymerase inhibitors. So we're very jealous of HIV that has so many different mechanisms of action. So we have virologic approaches, and I'll show you those, and host immune approaches. So interferon is a very potent host immune activator against hepatitis B. The RIG-I agonists had just stopped. The study was halted a few months ago for hepatotoxicity. TLR7 and 8's being studied, PD-1, PD-L1. We're studying both of these and TLRs in the ACTG. Therapeutic vaccines have been studied for many years and not successfully, but they're being restudied, so we'll see. So the next slide shows all the different places where these new direct-acting antivirals against hepatitis B are being studied. On the left in blue, Mercludex is an entry inhibitor and has been very successful in hepatitis B and D in driving down viral replication while you're on treatment. It stops the virus infecting other cells, but it doesn't turn it off completely. Then you go down to the left, preclinical. The ultimate would be to be able to inhibit cccDNA, and that's the hope to cure hepatitis B. If you can eradicate cccDNA, we don't have those studies. There are some being evaluated in the laboratory at the moment. I think we will have what we call a functional cure. So remember I told you when an adult gets hepatitis B, over 95% of them lose surface antigen and have antibody to surface and antibody to core. That in the literature is called a cure. And it is unless you get immune suppression, because you still have cccDNA in the liver. But a functional cure is what we're aiming for, and we think we're going to get that in the next 5 to 10 years. A virologic cure is the ideal, and that will come with time, and that will probably take a decade or more. So if we go back, I explained to you that MYR is Mercledex, an entry inhibitor. Preclin is preclinical studies of cccDNA. The next one is siRNAs, which inhibit the translation of mRNAs into viral proteins, and they're in phase 1 and 2 studies. The next one, CPAMs or CAMs, which are capsid inhibitors. So core and pregenomic RNA form a nuclear capsid, then you assemble it to develop the whole virion. So capsid inhibitors are being studied in phase 2 and going into phase 3. NAPs are nucleic acid polymers, which are assembly and secretion inhibitors. And these are the ones that have shown in small studies in Europe and Asia and Western Europe, Eastern Asia, if that makes sense. Yes, it does. That they can actually remove surface antigen. And the ACTG was going to do a study of the NAPs, but I think they will come in the next year or two. And combination therapy, just like in HIV, you know, in HIV, you get integration of the virus. In hepatitis B, you get integration of the virus into the host genome, predisposes to cancer. And you also get this little episome of cccDNA, which is a mini chromosome in the nucleus that can be turned on even after everything's finished. So I think that new Hep B drugs are exciting and will come in the near future. Whether any of these, I mean, some of these already core inhibitors have been stopped for toxicity. The first siRNA was stopped for toxicity. So it's going to be like any other drug development. Many drugs will fall by the wayside, but there are over 40 drugs in the clinic at this time. So it's an exciting time for hepatitis B that we can add at least 1, 2, 3, 4 drugs to our armamentarium. As I said, we will cure to a functional cure, but removing cccDNA from the nucleus is really the ultimate goal, and we're nowhere near that yet. So that's my answer to the question of curing chronic Hep B. TAF, weight gain, and metabolic syndrome in core positive. Well, I think that you have to take, what are the biggest issues? Yes, patients with TAF can gain an average of 1 kilogram if you look at the data that was shown yesterday. But the metabolic syndrome adds way, way more than that. And so I would more aggressively treat the metabolic syndrome with diet, exercise, treat hypertension, treat cholesterol, that you get much more bang for your buck than switching off TAF. Of course, if there are other options that are perfectly successful, if you can go to a tenofovir regimen, fine. But I think that the focus in fatty liver should be the focus on the metabolic syndrome and obesity first. So the Cuban study with 10%, I took out my slide of weight loss, that the 10 in other studies, the small 10%, 2 to 5% weight loss improves steatosis, 5 to 10% improves inflammation, and 10 to 15% for fibrosis. And certainly it's true that weight loss can cause resolution of NASH, but maintaining weight loss is a big problem. And after cure of HCV to Alex Stanford, do you consider monitor for fibrosis progression? Yes, if they have intermediate or severe. So if they have F0 to 1 before cure, you don't need to monitor unless they have comorbidities. If they have comorbidities or they have intermediate fibrosis, you need to monitor for progression. And you can monitor with a FibroScan for progression. It's just not good for regression. So F0 to 1, I don't recommend the need to monitor if the patient doesn't have another cause of liver disease or metabolic syndrome.
Dr. Peters, this is Antonia. I just have a quick question about the Hep B, even in non-HIV, because of course this continues to perplex me. But as a transplant ID doc, we get a lot of consults, even from rheumatology, for these core positive patients who are going on immunosuppressants, or from dermatology, for instance, or people headed into transplant. And it seems, from what I'm understanding from what you're saying, is even if we try to booster vaccinate, we cannot trust the fact that if they're going to be highly immunocompromised, they are not at risk of reactivation, and that we should be advising to start an antiviral medication through their immunosuppression, even in HIV negative patients.
If they're high risk.
Yep.
If they're high risk. So rituximab, sure.
Anti-TNFs.
Anti-TNF. Now that's an interesting question. If you have a 50-year-old Asian lady from the Bay Area who's anti-core positive, you want to be sure she doesn't have cirrhosis, right? Because she could have lost her hepatitis B last week. I mean, last year I had 5 patients who lost surface antigen who were in their 50s and 60s. So if that person had come to me next year or the year after, or gone to the dermatologist, rheumatologist, or oncologist, they might have said, oh, you're nothing. But some of them had cirrhosis. 2 of them had cirrhosis. So that's a big worry. So you need to make sure of that. And if it's a frail person who's not going to be able to tolerate a flare in hepatitis B, I put them on treatment. I actually recommend treating anti-TNF, even though it's only 5%. Whereas rituximab is over 10%. Now, steroids is in the 2%. Now, if you look at some guidelines, they recommend treating that. So we actually made a guideline for UCSF and infectious disease and hepatology, so we'd all agree, because everybody had their own opinion. One of my colleagues says, treat everybody, no matter what immunochemotherapy you're going to put them on. But we thought maybe not. So I'd be happy to share that with you if you send me an email.
That would be wonderful.
Send you
because I know that
guidelines.
we have a lot of discrepancy, like you said, amongst GI and the risk even within the anti-TNF category. And then we get also the rheumatology and dermatologists who use a lot of these immunosuppressants, and finding these isolated core antibodies has been difficult on how to uniformly manage that population.
So I think it's easy to respond. If it's high risk, yes. If it's intermediate, probably yes. And if it's low risk, no, except you have to look at the patient. So if and you have to say to yourself, does this patient have cirrhosis before he or she lost surface antigen? And would this patient tolerate a flare? And if your answer is yes, yes, they might have progressive liver disease, or 2, they wouldn't tolerate a flare, I'd treat them even if they're at lower risk. And then we have a big argument of whether the AASLD guidelines said you should treat with tenofovir or entecavir. The ID guidelines say you can use lamivudine. So I don't have an answer to that. I have one patient who we put on lamivudine who was anti-core positive. Stem cell transplant, very high risk. He developed, he seroreverted, developed lamivudine resistance, entecavir resistance, and only got treated on tenofovir.
Dr. Peters, for your co-infected patients who are core positive, do you just always have them on dual therapy, even if they're surface antibody positive then, because there's the possibility of reactivation?
I do, because then I don't have to think about it. I mean,
Okay.
I don't do it. I don't choose the antiretroviral.
Oh, got it.
I recommend it,
Okay.
because then I say you don't have to think. When the patient gets lymphoma, you don't have to drag it into your brain. It's already set. It's
Okay.
the real problem when the patient has renal disease and you put them on TAF and they still don't look good, and they're the ones that are a challenge. But then I tell the patient, I tell all my patients, you're cured, but you're not really cured if you end up having some terrible disease that needs chemotherapy or stem cell transplant. You have to remember that. So just call me the day before you get it and I'll get you on treatment. So it's the patient can remember something serious, whereas you have hundreds of patients. It's so hard to remember all the little bits and pieces.
Thank you.
Hi, Dr. Peters. A lovely talk. And I wanted to ask you a question about fish oil and use of fish oil in patients with HIV and hepatitis co-infections or NAFLD, especially in patients who have high triglyceride levels.
So there's no contraindication to fish oil at all. Whether it's beneficial, we don't have randomized controlled studies, but certainly there's no contraindication.
Thank you.
And FTC is an anti-hepatitis B medicine, but it's a wimpy one. It's like lamivudine. We don't consider it good. It has some effect. You don't see it in the guidelines because TAF, tenofovir-based regimens and entecavir-based regimens are the potent ones. The others are wimpy. Why choose a second-rate drug when you can choose a good drug? We've nearly come to, we have 2 minutes if anybody has a burning question or some confusion I left you with, which I can do frequently, apparently. No. Well, let me know if there are any issues, and I hope you enjoy the rest of the time. Thank you.